I'm going to be summing up the day by talking about how the information we've heard today could be incorporated into our everyday practice. And we have, in South East London, have a little bit of experience with this because 2007 to 2009, we were involved in a pilot study. My team, the Three Boroughs Primary Healthcare team, was involved in a pilot study jointly with the local health protection unit looking at the feasibility of carrying out new entrant health checks in primary care. And this is in a context of working in Lambeth, where we have a high population churn, 10% of the population coming and going each year. 30% of our population are born outside of the UK, compared with the UK of 12%. And our largest minority groups are Black African and Black Caribbeans, 10% each. So I'm going to be talking about why new entrant health checks might be a good idea. I'm going to be drawing on experiences from our pilot study in Lambeth, and I don't claim to have any answers to the concerns and the questions about practical problems in GP surgeries that have been raised throughout the day today, just possibly throwing up some ideas. So why new entrant health checks? Well, many migrants to the UK come from the country with high burden of infection, and this is just recapping what people have said today. More than 70% of new cases of HIV in heterosexuals, of TB and of malaria diagnosed in people born abroad, and 80% of Hep B infected blood donors were born abroad. So early detection is very much the key for reducing disease burden and costs, and it's crucial that primary care becomes involved in this. Additionally, additional to the health protection benefits, new entrant health checks can be an opportunity to check for additional needs related to migration. And there may be specific needs related to circumstances in which people have come to the UK, for example, the specific needs of an asylum seeker with a history of torture as opposed to needs of a family of migrant workers on a low salary. There may be an opportunity to provide health promotion advice and to diagnose non-infectious diseases, and also to give information about the NHS, because that really will increase access to healthcare. So this is my first plug of the HVA Migrant Health online resource, which has some very useful information, general information about new entrant checks in migrants. So what do we know about new entrant screening? Previous studies have all been on single diseases, as far as I'm aware. Apologies for not putting hepatitis on there. I just heard today that there have been some studies on that in new entrant screening in primary care as well. And the studies that have been done have shown acceptability and feasibility, mentioned this morning as well. But the current centrally funded programmes for new entrant screening are for TB only, and the port of entry screening programme has been shown to be costly, ineffective and discriminatory. There are some regional, more holistic new entrant initiatives. For example, there's a service in Belfast which is primarily targeting asylum seekers, and a lot of asylum seeker services around the UK which do holistic screening. But there was an example in Slough, the East Berkshire New Entrant Screening Service, which provides holistic screening with a health protection focus. So I just wanted to mention some data from the service which I work in clinically. My own clinic is a service for destitute refugees, because I think that just illustrated the acceptability of providing bloodborne virus screening in primary care. The data, unfortunately, is quite small. We only had 112 destitute asylum seekers in our sample in that year. And our patients are offered a screening package routinely as part of their first assessment. And that's primarily for bloodborne viruses, and we take a TB history. And almost all of our patients agree to have it if it's presented as routine and part of our service. And the only refusals for HIV testing that we've had have been from people who had a history of rape, particularly people who'd been repeatedly raped and had high levels of distress, and they felt unable to possibly to cope with a positive diagnosis. We offer those patients the possibility of coming back to us later once their life gets sorted out and they become a bit more stable. The results, as I mentioned, are probably not statistically valid, but we've shown in our group quite high rates, 6% of adults HIV positive, 6% Hep B surface antigen positive, and 2% Hep C antibody positive. So moving on to our pilot study, mentioned Lambeth, the highest diagnosed HIV prevalence for any UK local authority area. So this is 14 per thousand for people aged 15 to 59 in 2010. And we had a relatively high for London TB incidence in 2005, which was 51 per 100,000, has come down to 34 per 100,000 in 2011. We worked jointly with the Health Protection Unit because they had a particular interest in this project for these reasons. And we got a small grant from a charity for providing some funding to the practices taking part. So we recruited 3 practices and wanted to complete 200 checks. So what did our intervention consist of? We targeted practices in areas with high proportions of migrants, and I visited each practice to brief the whole team. And then I did a separate one-to-one session with the practice nurses about the software and the contents of the checks. And we had a further educational visit for all practice nurses by the bloodborne virus specialist nurse practitioner. We created a template on our email system for prompting questions and capturing results. And we also already had links with our local TB specialist nurse team and had an easy access referral pathway to the local TB clinic. And we paid the practice a retainer fee and a fee per check. So this is our EMIS LV, one of the screens from the testing screen. It's not very easy to use on this particular IT system, but I think with all practices migrating to EMIS Web or using PCS, it's going to be a lot more user-friendly. So who was tested? We compromised a little bit on this. This maybe wasn't clinically the most appropriate cut-off points that we chose. We decided to include everyone who'd been in the UK for less than 2 years. But clinically, that probably doesn't make so much sense. The reason for doing that was that we needed to actually reduce the number of people coming through to have the checks. So we didn't use a larger cut-off point. With a cut-off of less than 2 years, you would only capture 24% of new TB diagnoses in migrants. Chris mentioned this morning, 55% of patients with new TB diagnosis in London had been in the UK 5 or more years, so we would have missed a lot of people. And most TB screening projects choose a time interval of 5 years. The patients that we included needed to have been born in or had spent at least 6 months in a country with a high annual incidence of TB, of 40 per 100,000 or more. And the reason we chose TB incidence as our key indicator for including people in our study was that in 2007, all the countries with an incidence of 40 per 100,000 of TB also included the countries with high prevalence for HIV, Hep B and Hep C. I don't know if that's still the case. So by using that as our cut-off, we were able to sort of capture most of the people that we wanted to screen. I'm not sure whether that is the most sensible way, but it was a very simple way of doing it. We gave all the new registrants in the practice were given an information leaflet in an appropriate language, and we had 10 different local languages. And they were also given a list of eligible countries of origin. And if they felt that they were eligible and they wanted to take part, they could book an extended check, which was a 40-minute appointment with a practice nurse and a follow-up appointment. This is our list of countries. And as you can see, there's all continents are included, and including quite a number of European countries. And this is our information leaflet. So we kept the checks quite simple. We had bloodborne virus screening for HIV, Hep B, Hep C, and we weren't able to do the TB screening in the practice for practical reasons. And because we had good links with the TB clinic, we set up an easy referral pathway and followed the nice 2006 guidelines to the letter. And we also offered catch-up immunisations as per the HPA flowchart, which was mentioned this morning. This is the excerpt on new entrant screening from the 2006 TB guidelines, which I'm sorry if that confuses anyone, because they have changed quite a lot for the 2011 guidelines. So I'm just putting that up to illustrate what we were doing back in 2007. And this is the referral form which was attached to EMIS and came up automatically when people were being seen. We had to unfortunately abandon our pilot study because there were some organisation problems in the practices, nothing to do with what we were doing itself, but we don't have a full set of data, unfortunately, from this project. But from the debriefing interviews with the practices, we did learn some valuable lessons. We found that overall the checks were very acceptable to patients, and particularly bloodborne virus testing was highly acceptable. Some patients were reluctant to be referred to a chest clinic, and this was particularly because they felt that having a chest X-ray, which was then part of the guidelines, would be a strange thing to do in a healthy person, so that was difficult. We found that practice nurses needed a lot of support, and a champion within each practice was really important. There was also a cost factor. 40-minute nurse appointments is quite a long time in a GP surgery's nurse clinic. We actually found the nurses asking for longer after they'd started doing the checks, so asking us for longer appointments. You have to bear in mind the interpreting factor, so we'd always say, allow an extra 40% or so of time for interpreting. So it's actually maybe only 20-25 minutes that you have. The nurses took part thought that because what they were doing in these checks was quite different from their usual practice, they would prefer to see all the new entrants in one separate clinic and to block book them for practical reasons as well. So there are some practical issues relating to how these checks could be fitted into a kind of practice day that need to be resolved. But what is needed to make the checks a success? I think incentivising the checks for practices is very important. We probably didn't give the practices enough to make it really worthwhile for them. That was a valuable lesson because there's so many pressures on primary care, and we were not perceived as a priority. The educational programme to accompany the checks was really important, and I think one of the reasons our project fell down in the end was that there was such a high staff turnover, and we would have needed to renew that educational programme on a periodic basis. You need supportive IT and minimal inconvenience to patients. Just one example is that one of the practices had a large working young migrant population where patients didn't want to come during the daytime. They didn't want to disrupt their newly started jobs coming for a screening appointment. So that you need to work around that. I wanted to suggest that there's at the moment two models for new entrant check services. One is this kind of centralised model that you get, for example, with the East Berkshire new entrant screening, where you have a central service staffed by somebody who's more expert, for example, a former TB nurse or a health visitor, and who receives referrals from GP surgeries, from the Port Health Service, from UK Borders agencies, from community organisations. They carry out an assessment, they do all the screening and feedback to maybe to the GP surgery, or they may refer someone onto the GP surgery who isn't already registered. There's some advantages to that kind of service, which is that they have more time, they can do more holistic assessment, they can promote health access, but they may not be suited to all areas and to all kinds of configurations of migrant populations. And the other model is what we were trying to pilot in Lambeth, which is that the screening is located in practices. And the advantage there is that there's better integration, for example, with referrals for further care, that it promotes dissemination of knowledge. If the work is just done in specialist services, it doesn't spread out to the rest of the health community. And also that the screening or the detection of disease can be opportunistic as well as being systematic, so it can take place throughout the time that somebody is registered at practice. And there's possibilities for combining it with a centralised service that could provide some training and coordination. But unfortunately, at the moment, we don't have much of this anywhere. So in the meantime, I think the message is to raise awareness in your practices, to maybe develop local or practice-based protocols, to integrate global health thinking into your consultations, and to use electronic resources that can help you, for example, the prompts on the IT system. And again, I want to come back to the Migrant Health website, just giving an example here that if you're faced with somebody from a country, you have no idea what's going on there, the Migrant Health resource is country-based. It has an A to Z list of countries. Using Angola here, it's telling you that you should be screening for HIV and TB, and thinking about hepatitis B and vitamin A and vitamin D deficiency, and somebody coming from that country. And the website then also gives you links to infectious diseases information and links to NICE guidelines, etc. So there we are. Thank you.
Thank you very much.